This is going to be a crash course in everything that you've ever wanted to know about placentas. First of all, let's just talk about the origin of placenta. Like, what is it? It's actually the baby's genetic twin. This is where some of these things like preeclampsia risk, fetal growth restriction risk, whether or not you have something like placenta accreta, and just placental insufficiency, or like potentially the cause of miscarriage. Another thing that blows people's mind is that maternal and fetal blood never mix. Embryology is really fascinating. It can be a little bit dry, but then honestly, it's like magic before your eyes. Welcome back to Healthy as a Mother, and I'm your co-host, Dr. Morgan McDermott, and this is the show for becoming and being a mother, where Dr. Leah and I share our natural women's health and motherhood guidance that you've been looking for through our fresh, functional, and balanced lens. And today you are going to learn every single thing that you weren't even aware of that you wanted to know about placentas. We're going to talk about how the placenta forms and how sperm actually has a huge role in that and the man's health. We're going to talk about different placental varieties and positions, and then some issues that can come about with the placenta, the way that placentas can be birthed, active or expectant management. And then we're going to talk about the things that you can do with your placenta afterwards. Like, do you want to eat it, bury it, etc. So you're going to learn a lot. And I think this is a really cool, it's medical, but it's also practical and hopefully interesting and not super dry and boring. We try to keep it a little funny and light throughout the whole thing. So I hope you enjoy. Let's dig in.
We're back.
Woohoo!
Woo! And we are talking all about the most exciting topic you've probably ever heard about, which is about placentas. Everything placentas. Dr. Morgan is going to enlighten us with all of her wisdom and knowledge about the placenta. Obviously, most people probably know listening to this, but if you don't, well, I guess you're going to talk about it, but it is, the thing that nourishes your baby as it grows. And it's kind of, to a lot of people, probably very mysterious. Even to me, I feel like I don't know that much about the placenta, like not as much as you do. So why don't you just share all of your wisdom and knowledge?
Yeah, this is going to be a crash course in everything that you've ever wanted to know about placentas, including
And things you didn't want to know, things you probably weren't curious about, but now will be an expert on.
That's true. Everything that you didn't know that you actually thought was interesting about placentas. That's what we'll call it.
Perfect.
Okay, we're going to talk about the origin of the placenta, like how is it made? We're going to be talking about the function, the different varieties. So that's why I came up with this episode. Was I was continually getting questions about some of the placental anomalies that it can occur, something like Velamentous cord insertion or vasa previa or lobed placentas, marginal cord insertion, etc. And so people were like, "Do you have any information about this? I was just diagnosed," and we didn't, but now we do. So we're going to talk about placental positioning, placental issues, like some of the problems that can come up with placentas, the birth of the placenta, and then what to do with it after. Like, what are your options for afterwards, including like, should we eat it or not? Things like that. So, because people always want to know my opinion about that too. And that's evolved and changed in time. So I'm just going to hit the ground running. This is like a little biology placenta 101 for everybody.
Great. And I know it might not be in your original outline and you don't have to touch on this, but if you do and in your knowledge as you're talking, I would love if you have any insight on the development of the placenta in early pregnancy, because, I work with fertility, so there's a lot of pregnancy loss, and one reason for pregnancy loss is an unhealthy placenta for whatever reason, XYZ. And so it's not like, that's also a conversation to have. It doesn't have to be in this episode, but just
no, it is. It is in this episode.
Yeah, perfect. Okay, because that is something I am really interested to learn more about, what you know about. So yeah, keep going.
No, yeah, we do talk about that a little bit because, recently I feel like there's been some content out there that's talking about how the placenta is more sperm derived and male health and how that has to do with like the preeclampsia risk of the woman. And so then there's been all this stuff like male health is female or sperm health is pregnancy health or is like woman's health.
Yeah.
Because it's going to affect the way that your
I've been saying that for years.
Yeah.
Men's fertility is a women's health issue. So.
Yeah, and it's true. It affects a lot of things. So, okay, first of all, let's just talk about the origin of placenta. Like, what is it? It's actually the baby's genetic twin. So, placenta is baby. And this is why in a lot of cultures indigenously, and I know that this is for like the very end of the episode, but some of the traditions around what people have done historically with placentas comes back to this original idea that it's the baby's twin. And so like burying it where the baby is from or where their tribe or their culture is from sort of anchors their soul for the afterlife where they can come back and they're anchored there, and it's sort of like a
Mhm.
special honorable thing to do. So the sperm idea, so because the placenta actually is genetically the same as of the baby, it's still 50-50 sperm egg. Okay, like it's still going to be that. But there is a push pull of paternal genetic interest and drive in the genes versus maternal genetic interest and drive in the genes. And so when it comes to the placental development and what it actually is doing in the very beginning, that has a very strong paternal gene expression dominance. And this
Mm.
is why it matters. So when you have a conception and as your little, sperm and egg meet, it starts to divide into, 2 cells, 4 cells, whatever. It's going astronomically fast. And this little ball of cells, this little morula or whatever, blastocyst, is floating down the fallopian tubes, and then it comes into the uterus and it picks its spot wherever it's going to implant. And as it implants, what is happening is it's burrowing into the side of the uterus, into like the lush endometrial lining, which is why we want to have a good, solid endometrial lining for the baby in order to implant. This is why, like, super light periods, although people will be like, woohoo, I don't have a great period. But it's like, no,
Mhm.
that actually is a problem because there's not enough. Imagine trying to plant a seed in like a quarter inch of dirt,
Mhm.
like,
Yeah.
or an eighth of an inch of dirt, I guess I should say, because it's just not enough. You need like at least an inch to start a seedling. Um, it's not that exact scale in the uterus, but I'm just
Mhm.
saying. So then what happens is immediately there is this kind of like differentiation between layers of the embryo, and the ones that burrow into the side of the uterus are the placental. They're going to be the placenta, and the
Mm.
ones that are growing out into the uterus are going to be the baby and the fetus. And so there's like this split now, sort of, where it's still 50-50, mom and dad, but the expression of the genes is heavily paternal on that side that's becoming the placenta. And one of the most important things that it has to do is have this really deep, not shallow, but a deep and robust infiltration of cells that are going to connect spiral arteries and become the whole outline of the vascular system from which the placenta is going to connect
Mhm.
to the inside of the uterus. Okay. And so this literally step, this is where some of these things like preeclampsia risk, fetal growth restriction risk, whether or not you have something like placenta accreta, which is where the placenta abnormally grows into the muscle lining of the uterus, and it's,
Mhm.
it can be very bad. It basically always requires cesarean because it cannot slough off properly. It's not just in the lining, it's in the muscle.
Mhm.
um, so this is where all of that stuff can dysfunctionally kind of go wrong. And if you have poor and just placental insufficiency, or like potentially the cause of miscarriage, because if we have
Yeah.
poor infiltration, if the placenta is not implanting deep and robust and connecting all these arteries, then we're going to have poor nutrient transfer the entire time.
Or clots. So you can have
Yeah,
microclots if you have a history of clotting, and that can happen in these early times when the arteries are very little, and these little microclots kind of prevent that blood flow.
exactly, exactly. And so what's kind of cool, I like this. I feel like it sort of goes along with masculine and feminine energies, is that
Mhm.
the the placenta and the paternal genes
I see
are.
where you're going, and I can't wait for
Do
you
you see
to
it?
reveal it. I see it.
So the paternal genes are like setting up shop and house and
Oh,
providing.
foundation.
Okay, yeah, the foundation. They're like, "Oh my God, it makes me want to cry." It's like, "Hey, baby, okay, we're gonna like protect you. We're gonna get everything going on with this." And then the maternal interest genes are creating like the fetus. And
Oh,
they're more about
so
the
beautiful.
going in and jutting in. And just in this like early phase, this is, and it kind of goes back to a balance later on, but in the beginning there's not a balance. And this is all happening at like, you know, in the time of implantation in the first like 2 weeks of pregnancy. Like people don't even sometimes know that they're pregnant yet.
So the
um
placenta is the provider, and it's infiltrating to go out and provide for the fetus by bringing in nutrients and blood flow. And so I love it. It's the analogy in my head. It's great. I love
it's
it.
beautiful. I know. It's great. It all comes back together.
I
We're just
know.
so obsessed with this whole thing.
That's
I
great.
sometimes wonder about myself because I have a bit of an obsessive personality. Like I get
Do you?
very,
I'm
you know,
shocked.
I was gonna
That's
say,
called sarcasm.
okay, good. I get like very into a topic
Yeah.
and, deep dive into it. And I'm like, is there going to come a day where I just like don't care about any of this anymore? And
I've literally
honest,
wondered that. I've wondered that about you because I know that about you. It's the longest I have observed in you, because I've been your friend for 17 years, that your obsession with birth is the longest obsession I've ever witnessed you have.
thank you. I don't think it's going away. And even if when I'm done with babies, I'm still going to have that reverence. But I would say probably when I'm like total, I don't know, when my youngest is like 10 or something, I'll probably be more interested in whatever the topics are that are coming up with like
Yeah.
teenagers. And
Like, what are you? Yeah, what is going to be your new obsession when you're done with birth? I think about that a lot.
I
I'm like,
don't
what are
know.
you going to do? Like, what's it going to
Menopause.
be?
I've kind of always thought like maybe I'd get into, menopause stuff,
Yeah,
medicine. I don't know.
jump that whole spectrum. That's good.
Yeah, the whole thing, baby, from the beginning to the end. But anyways, okay, so this is where poor male health actually does impact the pregnancy itself, the mother's experience of the pregnancy, the baby's health. So the factors that can affect sperm the most, which can also then now affect placental function, would be things like oxidative stress. So from having, doing factors, things like smoking, other drugs, illicit drugs. Cocaine is one of the worst things for sperm. But even like cigarette smoke and weed smoke, bad, bad, bad. Having a chronic illness or obesity where there's this chronic constant inflammation and stress on the body, things like pollution or toxic exposures, metabolic stuff like insulin resistance, and then of course micronutrient deficiencies, specifically with like zinc, selenium, folate. So this is why we have good sperm health supplements that we prefer people be on for several months to give, yourself the best bet. And it takes at least 3 months. So if you start sperm health and then you conceive 1 month later, it will have done nothing for that particular baby that was conceived. But,
Mhm.
you know, don't beat yourself up. Sometimes people don't get to do any preconception care at all. But this
Yeah.
is also why it's interesting. Like when women have had multiple partners, they've had children with multiple different people. Sometimes they have completely wildly different pregnancies, including like HG. So like hyperemesis gravidarum is
Mm.
not like, oh, I'm just a woman with HG. It's like there's something to do with the sperm in that. We don't know exactly what it is. Maybe it has to do with this placental functioning. But sometimes if a woman has a partner and they've had that experience, then they have a different partner, they may not. And
So really, I just need to find a different husband. It's
well,
Mike's fault. Mike's fault is why I vomited my entire 2 pregnancies.
yeah,
Yeah,
so I mean honestly, like this is
it's
where
interesting.
there is a lot more responsibility on the male side than has been previously given
Hmm.
thought. Okay. And then of course, like, being inflamed for any reason or very advanced paternal age too. So, okay. So that's kind of like the beginning of how this all breaks down. And then now this part is a little hard to understand, but I found an analogy that I think will work. And the reason why I need to even talk about it is because then when I'm talking later about certain placental variants and anomalies, we can be accurate.
Hmm.
And so, okay, a lot of people think that there's your uterus and then there's a membrane around it, and that's your amniotic sac membrane. And then the baby and everything else is inside of it, including
Hmm.
the placenta and the cord. And they think like it's all just floating in this sac, but then like somehow the placenta is attached. Okay, it's not actually like that. There is
Mm.
2 layers of membranes on the outside. So it goes uterus, we're going to go from the outside in, and then we'll do the other way around too. So first outside in, and I'm going to go kind of slow. We have your uterus.
Hmm.
Then you have an inner membrane on the inner side of the uterus that's touching the uterine wall that's called the chorion. The placenta is basically like a thickened part of the chorion. So like on the edges after placenta, placenta is like a defined organ. And at
Hmm.
the edges of the placenta, imagine that it just becomes this very thin membrane and it goes all the way around. That's called the chorion. Okay, so that's the outer wall. And the placenta is in that. Like it is part of that. It is the chorion. Okay.
Okay.
Then you have extending from the placenta. Well, okay, so then imagine like vacuum sealed wrapped on the
Mm.
inside of the chorion, and all around the placenta is now the amnion. And inside the
Mm.
amniotic sac, inside the amnion, is the baby floating in this water. The layers are right next to each other. The chorion and the
Mhm.
amnion, there's almost like no space in between. And they're just like two sacks. Like you have two
Like putting two Ziploc bags, like one
yes,
Ziploc
inside
bag
of
on
each
the other
other.
Ziploc bag. Hmm.
Yes, exactly, exactly. So the analogy that I found is like the chorion is the wall, the amnion is the wallpaper.
Oh, I like that.
Okay. And extending from the wallpaper, like wrapped in wallpaper, is like the cord is wrapped in the wallpaper and it creates
Mm.
this big like pocket
Mm-hmm.
pouch and the baby's inside of that.
Got it.
Okay. So like your baby can never reach out and touch its placental tissue directly. It can like
Mm.
feel it, like it's like feeling a pillow underneath your pillowcase.
Yes.
Because it's not, but it's not going to be able to like scratch and like damage it. I think sometimes people have anxiety about that. Like, well, what if the baby like with their
Mm-hmm.
sharp nails at the end of pregnancy like scratched and caused like a bleed on like a vessel
Mm-hmm.
or something? But there is protective layers. There's technically
Mm-hmm.
two. There's the amnion and then there's the chorion. Well, it's part of the chorion, but anyway, it's never touching directly. And now the baby's umbilical cord, it can like grab, but still, even the umbilical cord, as it comes out from their stomach, it's immediately all the way wrapped in the amnion. And then it goes up and it creates this like little bubble all around them. Okay. And the
Mm-hmm.
umbilical cord continues to go through the amnion, through the chorion, and into the placenta. That's how it
Okay.
inserts. It's very difficult to understand. I get that. It is. Okay, so now
Mm-hmm.
let's just do an inside out. So you have your baby floating in space
Mm-hmm.
in water. That's the only place where water is.
Okay.
Okay. And its umbilical cord, as it's coming out of its body, is covered in a membrane called the amnion.
Mm-hmm.
Underneath the amnion, the umbilical cord itself is also has this white stuff in it called Wharton's jelly, and that covers the vessels.
Mm-hmm.
So it goes amnion, Wharton's jelly, vessels. That would be like the three layers of the umbilical cord. Okay. So right at that part, it goes the umbilical cord coming out of them, jutting out of them, is covered in amnion, and it goes and it connects and it goes through the amnion, but like up around it too is creating this like little cavity. So the baby is in this separate little beautiful pure space called the inside the amnion in the amniotic sac in
Mm-hmm.
with the amniotic fluid all around it.
Yeah.
The cord then is going to go like through that membrane and directly into the placenta. And that placenta now is creating this other outer wall called the chorion. So it's
Mm.
actually not just like connected to, like the baby is not like touching the inside of your uterine lining
Right.
and stuff. You know what I
Right.
mean?
Yeah, that
Yeah,
makes sense.
there's these different
So the
sacs.
so
Okay.
the placenta is adhered to the uterine wall with this film around it, and then the baby is floating away from the placenta.
Yes, and actually the placental wall that's touching mom doesn't have a film in between it.
Mm.
So it's basically like directly if placenta is touching uterine lining, then on the edges of the placenta, like if here it is, I'm showing, so those who are watching on YouTube or Spotify, you can see, but it's basically like imagine you have a ball of putty and you're sticking it on a
Hmm.
wall.
Or like a mollusk, like a clam or something that's like attached to a wall.
Yeah, like a shell. Okay.
Yep.
And then like immediately if on the edges of where that mollusk's body was, if there was like a film that could come off of it and it would encase on the whole inside of the shell.
Got it.
So, but like the bottom part of the mollusk is directly on
Yep.
shell, but
Yep.
the sides of it up and around and where it creates this little like bubble cavity are not.
Got it.
Okay, so that's important because we need there to be direct contact between
Hmm.
that maternal side of the placenta and uterine lining in order for nutrient gas waste
Hmm.
exchange.
Got it.
Okay, that was like totally over your head. The whole episode's not like that, I promise. But I just I just
I
have
love
to
it.
say it. Okay, another thing that blows people's mind is that maternal and fetal blood never mix. It's not like, oh, my exact blood is going into my baby. Like, no, the baby, as the baby starts to develop, they have their whole own circulatory system and blood. Your blood never mixes. You do not, as the maternal mom, like give the baby their beginning of their blood or anything like that. So you
Hmm.
might, and this is where blood types come in and like ROGAM and that whole conversation is because you might be like O negative and your baby is AB positive because of the partner's side of things. And they're completely different blood systems.
Hmm.
Um,
That's
so
crazy.
yeah, it is crazy. And
Okay.
so the placenta acts as a filter and there's diffusion that's going across, but it's not like perfect. And this is
Mhm.
why there's a lot of things that we cannot do or take in pregnancy because they can cross the placenta,
Mhm.
including pathogens, like it tries, it does its best, but really
Mhm.
the placenta's purpose and its interest is in getting the baby good nutrient flow and good blood flow, um, and then blocking like certain stuff. But anyways, okay, so on to placental varieties and shapes. Most of the
Mhm.
time, the placenta is just one big blob, and most of the time, the cord comes out of the general middle area of it. Okay. But if the cord comes out of the side of it, like a balloon, like a flat pancake, and then you
Mm.
just stuck something into one of the sides, the edges, that's called a marginal cord insertion. And I had that with my
Mm.
first, and like almost all the time, it's benign.
Mhm.
Sometimes there can be like mild growth restriction stuff if there's maybe something else going on, but that is just sort of a variation of normal. Another one is a lobed placenta,
Mm.
where it's like instead of it just being one big chunk, it's broken off into like two different sections.
Mhm.
And the problem with this is that in between the two sections is vessels, and they are often exposed. And so there's a risk with that. Like there's a risk with those vessels maybe getting, ruptured or something.
Mhm.
It's not like it's too far of a distance usually, but still. And then the other risk with a lobed placenta is that having one of those lobes would be retained after the birth, and then you'd have what's called retained placenta, which has to be either manually extracted or extracted via dilation and curettage, DNC, which is like a full-on surgery
Mhm.
and no fun. Okay,
Right.
we'll talk about retained placentas later. The big main one that I get asked about a lot that is a variation that happens not too it's not super rare. Okay. And then there is one that is super rare. So a velamentous cord insertion.
Mhm.
Velamentous cord means that as it's coming, your baby's umbilical cord is coming out of its body, out of its belly, and it's going up through to meet the edge of the amnion, that inner sac. And as it's supposed to go in now through into the direct placenta, and it's kind of now surrounded by chorion, instead of going into the placenta, the Wharton's jelly part of the cord stops at the membranes, and then
Mhm.
out through the other side, those vessels then connect directly into the placenta, but they're exposed. They're
Oh,
not covered in Wharton's jelly. So it's like
okay.
instead of the Wharton's jelly going all the way through these two membranes, the Wharton's jelly connects into the membranes, and then the vessels are coming out the other side still,
So it
but
would
like
be
they
like
should.
having electrical wires that don't have the wrapping around it. All of a
Yes,
sudden, there's electrical
yes.
wires that are exposed, and then they can electrocute you.
Yes, exactly. It's like having exposed wires underneath wallpaper.
Got it. Yep.
Okay,
Makes sense.
so like without the Wharton's jelly, and we need there to be like wires underneath the wallpaper that have that like black casing stuff that keep it protected. As we're talking about birth and postpartum support, I want to share an underrated tip with you. That tip is to continue taking your prenatal. Pregnancy and postpartum are the most nutritionally demanding phases of a woman's life. Many women stop taking their prenatal after birth, but we recommend taking it for at least the first 9 months postpartum or the entirety of the time that you're breastfeeding. My favorite prenatal is Needed's Prenatal Multi, and it's the most robust formula that I've seen in the market. It contains bioavailable nutrients in their evidence-based dosages, well above the bare minimum that a lot of prenatals settle for. Their quality standards are top tier with transparent third-party testing and over 10,000 practitioners now recommending the brand. And now we have the results from their IRB approved clinical study that confirm the results of what we've been seeing clinically. Women who take the prenatal multi have significantly higher blood levels of critical nutrients for pregnancy and postpartum. This includes vitamin D, B6, B12, riboflavin, vitamin K2. Only women in the needed group reach the adequate, sufficient levels of vitamin D. Vitamin D plays a big role in your immune health, your mood, and your energy production, all things that are really important during your postpartum season. And while there's many different ways that you can support yourself postpartum, continuing to take your prenatal is a really simple, easy way to cover all your bases. It's one of the most impactful habits that we can have, and Needed makes it easy. Learn more about the study at thisisneeded.com/thrive and use code HEALTHYMOTHER to save 20% off your first order. Yes, healthy mother, like a little affirmation for yourself.
Yeah, because what would happen? Bleeding when
Yes.
when
So
vessels are exposed.
yes. So they're
Okay,
contained. The vessels are contained, but they're fragile.
got
And
it.
so sometimes, depending on how severe it is, because this is something that we would find on like an anatomy scan. This is why I'm so
Hmm.
pro anatomy scans, because sometimes it's like, oh, okay, there's a little bit of a velamentous cord, but we're all right. and we can still go on and attempt a vaginal birth. I feel like a lot of the time this is going to risk somebody out of a home birth unless it's very mild,
Mm-hmm.
because we do want to be able to manage hemorrhage in case it happens, because if those vessels are exposed, they're not as protected. So it just depends on kind of like what's happening, a lot of the other factors, and then the comfortability of the midwife in that setting. But going for a vaginal birth still is often possible unless it's a really severe situation. But they just need to be kind of careful and aware,
Mm-hmm.
and just like handle everything with a little bit more care. Now, the more rare situation that is much more dangerous and almost always requires a cesarean is something called a vasa previa, and that is where there is a section of the umbilical cord where there's no Wharton's jelly for like a long time,
Mm.
and it these vessels can cross then, and they can get in front of the baby's head and cross in front of the os, like the cervical opening,
Mm.
and baby could be like pushing on these vessels and cause like, blood flow blockage to themselves, or cause them to rupture because they're not covered in this slippery, because the cord comes in front of baby's head sometimes and it slips out of the way, because the Wharton's jelly is wild. You literally cannot tie a knot in it. I mean, like, true umbilical cord knots are one of the rarest anomalies that there are, and they're devastating because they often end in the baby not making it.
Mm-hmm.
But it's really hard to do that, thank God, because
Mm-hmm.
that's literally like the design of the Wharton's jelly, is it makes it so, it's like a jellyfish. It's like it's covered in jellyfish material, and you can't tie a knot in a jellyfish.
Yeah.
Like, it
Now, do
just slips
they
out.
do they know why some people wouldn't make enough of that Wharton's jelly? Like, does it require a certain amount of fatty acids that people might be deficient in, or is it
Mm.
totally a fluke thing? Like, why would some people not have enough?
I think it's just a fluke thing in the development of the whole beginning.
Mm-hmm.
It's like something did not function properly with the cells that needed to go there to say, you're going to cover this length to this length of Wharton's jelly and then no more. I mean, it's
Right.
so amazing. Embryology is really fascinating. It
I
can be a
know.
little bit dry, but then honestly, it's like magic before your eyes.
Mm-hmm. It is. It's crazy.
Yeah, it's crazy town. So, but it's really dangerous. It usually requires a cesarean because
Mm-hmm.
the risk is just not worth it. Um,
Now, would these require cesarean at full term, or is this like a risk for preterm?
Oh, good call. No, usually you could go to like pretty close to full term. Maybe they'd want to do it a little bit early because they just don't want you
Mm-hmm.
to go into labor and then
Right.
the cervix start to open up and either those vessels fall out and
Mm-hmm.
it's like a cord prolapse,
Mm.
or baby's head is like starting to push and there's contractions. Now there's pressure, and then now we can have like a blockage, a blood flow restriction.
Got it. Got it. Okay.
Um, so yeah, that's a good question. I don't know the nuance around when they usually do that. Probably what my guess would be like is 37 weeks. Is
Yeah.
That's usually
Yeah.
what they do when there's anything like that. They say, okay, let's get this baby as cooked as we can, and then we got to get him out.
Mm-hmm.
Okay, next up is placental positioning. Okay, not that exciting, although we will talk more about placental positioning that become issues in a minute. So
Mm-hmm.
you hear about people having an anterior placenta or a posterior placenta. Okay,
Mm-hmm.
so anterior is the front of your body. So an
Mm-hmm.
anterior placenta is going to be like right underneath your belly button,
Mm-hmm.
like, in that, or your lower pelvis or something, but on the front, like on your skin side, on your belly side, the front of your body. A posterior placenta is going to mean that it has attached in the uterine lining on the back side of your body.
Yeah.
This doesn't really matter other than your ability to feel your baby moving and kicking.
Mm-hmm.
So if you have a posterior placenta, the placenta's in the back. Like when your baby kicks you towards your spine, or is moving around towards your spine, you have way less. It's like towards your organs, and visceral nerve endings are way different. Thank
Mm-hmm.
God. Otherwise, we'd be able to feel like every little thing going on in our organs.
Lesson. Oh my God, that was terrible.
Yeah. We don't want that. Okay.
No.
So it's a good thing that we don't feel that much. But towards our stomach and, with our skin receptors and our muscles, like our abdominal muscles and stuff, we have a lot of nerve endings. And so if a baby is kicking out towards the front, we can feel it a lot easier. So when people have a big, huge organ in front and the baby's kicking, they just can't feel it until the baby's a lot bigger. And
Right.
so this can give anxiety to people until they know that maybe that their placenta's in the front, because they're like, I don't feel my baby. What's going on? And then
Mm-hmm.
eventually your baby will be big enough that at least you'll be able to feel kicks like on the sides
Yeah.
somewhere, where you see it. Like maybe you don't feel it that much, but you see it. Um, my theory is that all of the women, this is not correct, but all of the women in the world who have had full-term babies that they did not know that they were pregnant with had to have had anterior placentas. Because
Oh,
I'm just like, how on earth did you
right. How
not?
could you ever know? God.
I've had an anterior placenta one time of the 4, and it definitely was different. But man, for me, like, I mean, you can basically see an elbow jutting out
Mhm.
of my stomach when they're big, you know? And I was
Mhm.
just, I'm like, how on earth could somebody not know this is happening in their bodies? But it happens. It happens. I don't know.
Crazy.
So that's it about that. But then now let's go into the placental issues, and I'll start with the placental locations that are problematic. Okay, so the
Great.
one that everybody's heard about is placenta previa. Placenta previa is a low-lying cervix that is either partially or completely covering the os,
You
which
mean a
is like,
placenta, a low-lying placenta.
oh, what did I say?
Cervix. It's okay.
Oh, sorry,
You said a
a
low-lying
low-lying placenta that's covering this
the
opening
cervix.
of the cervix, which is called the
Yes.
os. So basically, it's like, imagine, you are inside of a balloon,
Mm-hmm.
and the organ that is creating you has implanted itself over like the tie part of the balloon.
Yep.
But you're supposed to come out from that hole though.
Yeah.
And you're like,
Problem.
what the hell?
Right.
And you can't. And so
Mhm.
sometimes if it's a partial placenta previa or something just called a low-lying cervix, which is not the same diagnosis as a placenta previa, but a low-lying cervix is concerning because if it doesn't move out of the way, even if it's not totally covering, sometimes if it has to be a certain millimeters away
Mhm.
for most practitioners to feel comfortable with attempting a vaginal birth. Because remember, the cervix is going to dilate to 10 centimeters.
Mhm.
So we need it to be far enough away that there's not going to be a part of the edge of the placenta that is now exposed and bleeding as the cervix, this hole is opening back up because it's attached.
Mhm.
And in that attachment is all of this vasculature. And so there can be a massive blood loss. And that's why this placenta previa, true placenta previa, whether it's partial or complete, requires cesarean because we cannot
Mhm.
have vaginal birth. And a lot of the people who are like super anti ultrasounds, no matter what, when they're asked about placenta previa risk and like, well, what about it? They're like, well, placenta previa almost always has bleeding at some point in the pregnancy, so then you could go get it figured out. And I'm like, okay, why would you? What? Like, okay, first of all, sometimes, yeah, you can have bleeding. And so sometimes people with placenta previa are put on pelvic bed rest. So they're
Yeah.
not allowed to have sex or work out. They really have to spend several hours a day, like lying down,
Mm.
because there can be some of this bleeding if it's like right there. And just, normal activity and stuff can cause a little bit of shearing and tearing in those vessels and then they bleed.
Mhm.
But also, why would we wait until,
I know.
I don't know, whatever. It's just like it's a philosophical thing. So,
Yeah.
like, for what? For the absolute zero impact of ultrasounds? I saw a really good post the other day that was like, accepting every obstetric intervention because of fear of your OB is just the same as refusing every obstetric intervention
Mhm.
from fear. It's still
Yeah.
from fear.
Yep.
Like for
Yep.
people who are like, no, get away from me. Never. No, I'm not going to do anything. I'm never going to like use these tools appropriately. Just it's still coming from a place of overall
Yeah.
fear
Lack
at the
of
root.
education, lack of educated and appropriate choices, in our opinion, because the tools are the tools and they don't always have to be used all the time, but in an appropriate way. You have to always weigh the risks and the benefits. Like in this situation, I would say the benefit of knowing if you have a placenta previa outweighs the risk of a single ultrasound, right?
Yeah,
Like
same.
the pros and cons of different things we have to take into account. Like there are some conventional things where the risk way outweighs the benefit. And in those
Yes.
situations, it's like that's what we have to take into account. And I agree. You and I are very much on the same page in that regard.
Yeah, that's good. What if we like got on here and we argued all the time?
Oh, be like, you suck. You don't know anything. That would
That
be
actually
really funny. I mean, I'm sure there are podcasts like that. Like
that would be kind
one
of
of
funny.
our friends who I will not name the name of would probably be a passionate podcast every time we
Oh,
chat.
I think I'm thinking who you're thinking, but that would be all about like politics.
Yeah, totally.
But anyways, okay, so that is the main one is placenta previa or having a low-lying cervix or low-lying placenta. But here's the thing. If you're diagnosed with a low-lying placenta at like 12 weeks or even at 20 weeks, so where the placenta attaches, it doesn't like slip and slide around in the uterus. It is there.
Hmm.
That is where it is. But as the whole thing is growing, like a balloon when you're blowing it up, the sides grow up. They
Mm.
grow and they go up. So imagine that there's something stuck on the inside of part of that balloon. As you blow it up bigger, it's going to migrate
Mm-hmm.
positioning simply because everything has to go up and stretch. And so don't get like super down on yourself about that just yet, because there is a good chance that it could move enough to have a vaginal birth and you don't have to have a scheduled cesarean.
Okay, you might get to this, but
Yeah.
when women are early pregnant and have bleeding, but it's not a miscarriage, is that typically a placenta previa, like a partial that's doing that, or is it something else where they go on to have a healthy pregnancy, but they have bleeding, early on, but it's not a loss?
Yeah, good call. Okay, so that's probably subchorionic hemorrhage, which we're going to
Mm.
get to. Just let me talk about the one
Okay.
other positioning thing that causes a problem, and then we'll bounce back up to that because that's a good
Okay.
question. So the other placenta location issue is the accretas, which I had mentioned earlier. And accreta is basically where in that early phase where it's embedding into your uterine lining, which is a like blood layer basically, like a
Mm-hmm.
thickened bloody. That's why when you that's what you lose when you have a period is your uterine lining.
Mm-hmm.
Okay, there's tissue in there and stuff too, but it's it's like a it's an area that can be lost, and it's like a thick soil of the garden. Okay,
Yes.
but if those little, they're called trophoblast cells, if the trophoblast cells embed too deeply, we do want them to go nice and deep. We want them to be good and proliferative so that we can have good perfusion of the blood, so good vascular organization and stuff. But if they go too deep and they go into the uterine line, like the muscle lining,
Mm-hmm.
because the
Mm-hmm.
uterus is a muscle. Now we have a placenta that is anchored into the muscle, and the muscle does not have this mechanism, beautiful design, to like shear off when the placenta needs to be expelled at the end of birth in
Mm.
the way that the uterine lining does. The uterine line, at when the baby is born, the uterine lining starts to like clamp off these arteries, and it shears off the connection of the uterus, or of the placenta from the uterus, pretty quickly. I mean, it takes a few minutes, but the process starts, so that the placenta can be born. We don't have to
Mm-hmm.
like do anything to it. We don't have to like, you know what I mean? It's so cool. It
Mm-hmm.
happens on its own. It's like, okay, I don't need to be here anymore. Bye.
Yeah, departing. It's like a spaceship. Like
Yeah,
I've landed, we have gathered our resources, and now I'm just gonna like take off. That's
exactly.
so
Eagle has
funny.
landed. Bye. See you. So if we have it into the uterine lining though, or the muscle lining, we have to have a cesarean to get
Mm.
that out. And it's very bloody, and there's a
And
lot of
how did they get it out? I mean, they're like pulling it and it's like pulling vessels out of the
scraping,
muscle, or
like
they have to cut it?
surgically
Like
kind of.
what
Yeah.
happens?
Yeah. That's a good question. I don't know about like the recovery of that. It can
Hmm.
be really dangerous though. And then there's
Yeah.
a couple of different subtypes of placenta accreta, like accreta with how deep it goes. I'm not going to get into that because it's like very rare, but
Did you know proper hydration and mineral balance are key for hormone health, fertility, and preparing for pregnancy? This is why Dr. Morgan and I love Relight by Redmond's, the real salt people. A USA made electrolyte powder with unrefined sea salt, over 60 trace minerals, plus bioavailable forms of potassium, calcium, and 2 forms of magnesium, malate and glycinate. These minerals support hormones, hydration, energy, and overall health. The best part is they taste delicious. I'm really picky about how things taste, and so you can rest assured this is Dr. Leah approved. I love lemon lime, but I know Dr. Morgan is a strawberry lemonade gal. Head to redmond.life and use code HEALTHYMOTHER to save 15% off your order of electrolytes, real sea salt, natural toothpaste, and so much more. Again, head to redmond.life and use code HEALTHYMOTHER to save 15%. Happy hydrating on your womanhood and fertility journey. One question about that, which you might
yeah.
not know, is there a higher likelihood of this when women have thin uterine linings? Because, the vessel is only so deep. Let's say it's a 3-inch vessel, and if your soil or your uterine lining is only a 1/4 inch, it has more of a likelihood to go into the muscle, or does that not seem to be a factor?
So the one main risk factor that I'm aware of, I don't know about that particularly, but the
Mhm.
one main risk factor I'm aware of is having a prior cesarean
Oh,
and it
interesting.
embedding into the scar. Yeah.
Ah,
So accreta almost
interesting.
always happens with a post cesarean uterus.
I wonder if that's why, because I had to do IVF, obviously, and I had a C-section for those who don't know. Before I could do my second transfer of my second child, they had to do imaging to make sure that I didn't have like a weird scar situation going on. I wonder if there's a piece about that of, I'm sure there's many reasons why they did that as far as rupture and things like that, just making sure it's healthy. But also, I wonder if there's a piece there where there's some clue where it would be more of a risk.
Yeah, and I wanted to ask you about that actually. When they were in injecting, not when they
And planting, yeah,
inserted the
inserting. Yeah.
embryo, do they like try to position it up and back?
I think so. Yeah.
Yeah.
I mean, they
Okay.
have a long tube, right? It's the craziest thing, you guys. I have this on video. They suck the embryo up into like a long tube-like thing, and then they insert it up past your cervix, up into your uterus, and then he goes to a spot that seems ideal. Like he's not going to be low down by the cervix. He goes
Yeah.
up deep and back, and then, you know, drops it. It's literally like pipetting, and it all the little fluid like comes out of the little thing with the embryo, and then it just plops it right there in my uterus. But they are able to position it. So
So
if
it
there
doesn't move
was,
around after that. It's not like
I mean,
floating in
it
the.
probably could, but I
Okay.
think for the most part, things are pretty sticky.
Okay.
And for the most part, your uterus, although is a balloon, before you're pregnant, the tissues touching each other. It's like,
Yeah, it's small.
it's like a sandwich.
Yeah.
So it's not like the embryo is going to go like flying all over the place. So
Yeah,
I'm
true.
sure there is a potential for that, but for the most part, I think they have a little bit of more say as to where it goes. I'm sure there's exceptions, but it's just like a seed. If you drop the seed in this part of the soil and hope that it stays there, there's a potential that a wind comes up and blows it away. But for the most part, it
Probably
will
not.
stay and just like stay in that area that they put it. Yeah.
Wow, that is so interesting. Okay, cool. Yeah,
Yeah.
they probably do put it in some sort of like viscous fluid so that it can't move around too much. Because,
It's
yeah.
probably like a saline of some sort. It's a good question. I really want to interview Dr. Chang, my IVF doctor, and ask him all these questions. It's
Do it. That
on
would
my
be
list
so
of things
cool.
to do. Yeah.
Okay, so let's talk about the other one that you mentioned, which is a subchorionic hemorrhage. So,
Hmm.
a subchorionic hemorrhage is where mom's blood, so not baby's blood, but mom's blood collects underneath where the placenta is attaching to the uterine lining.
Mm.
Okay, it's between the chorion there and the uterine wall. So, this blood is never going to get into the amniotic fluid where the baby is. We're not worried about that. And basically, it's like a stress point. Like, where because everything is growing so rapidly, like we talked about the balloon analogy, there is a certain level of pliability that the placenta's attachment point and the chorion's attachment points onto the inside of the uterus, they have to be kind of like flexible and pliable because it is growing so quick. If it was really rigid, it would like crack, you know?
Hmm.
And so sometimes though, there can be this like little bit of a stress point. It's usually on the edge of where the placenta is that lifts up and away. And so then blood collects underneath. It's like a little mini hemorrhage. So
Yeah.
subchorionic, so underneath the chorion hemorrhage. Okay.
Hmm.
This is a very common cause of first trimester bleeding, like you
Got
said.
it.
And it
Hmm.
can be a lot of bleeding, a
Hmm.
ton. It can be gushing. It's very scary sometimes. Like literally like a cup of blood falls out of you. It could also just be bright red spotting. Um, but I have a highlight on my Instagram, like a highlight bubble that is called SCH for subchorionic hemorrhage. That is of women writing in who'd had this experience that I screenshotted and I shared because a girl in one of my 6-week pregnancy call classes at the time was having one, and I wanted to collect and show her how many people have them and how much they bleed and then how the babies go to term.
Hmm.
Because almost all the time it's okay.
Yeah.
Sometimes it depends on the size. If it's over a 50% of the space underneath the placenta that is hemorrhaging, when there's that blood that's under there, it's like a clot. It becomes a clot of blood.
Hmm.
And now we
Hmm.
don't have as much oxygen and nutrient diffusion because
Mm.
we can't diffuse past that clot.
Right.
And so the body slowly reabsorbs it and will fix it, and it'll reattach properly in time. But again, it just depends on several factors. So in the first trimester, though, it's almost always okay. In the second trimester, this can be a lot more concerning, associated with things like miscarriage or growth issues in the baby, or um, placental insufficiencies and things like that. But it's much more common in the first trimester.
So
It's
is
not
this
caused by.
something that happens, it goes for a period of weeks, resolves itself, and doesn't really come back? Or once
Yeah.
you have subchorionic hemorrhage, it's sort of like you kind of have it the whole pregnancy, or do you
No.
have more of a risk of it coming back?
No. Nope. Once it goes away, it will reabsorb. It takes weeks,
Hmm.
and then it's fine. And you're not like at risk for more. They don't really know exactly what is causing it, but they know that like stress and sex and weightlifting and all of that does not cause it. So it's not like you did something. It's just
Mm-hmm.
that as things are, their best guess is that as it's growing, sometimes there is just this like little bit of kind of tearing that can happen almost,
Mm,
and the body knows how to fix itself, and it's cool, it's fine. It's scary for the woman because she'll bleed, um, because it's in that in between layer. Okay, so if we think about the layers, right?
mhm.
It's bleeding, and then it's kind of like slipping down the wall closest to the uterine lining and then out the
Mm,
os. If the
got it.
blood was happening in between one of the layers, like in the amnion, you would never have it out of your vagina. It
Right.
would be staying in that bubble. But it doesn't because it's coming from a space where it can get out. So there
Right.
is a small study that shows that 600 milligrams of ALA
Mm,
supplementation, alpha lipoic acid, alongside daily vaginal progesterone has a quicker reabsorption rate
mm,
of the, clot underneath this subchorionic hemorrhage.
cool.
It's a small study. It's not perfect, but it's really promising. And ALA is very like, it's a good antioxidant basically is
Hmm.
what it is. And so it's not like it's something that has a lot of concern for potential risk.
Hmm.
Something to ask about with your doctor. I've definitely seen midwives and OBs giving this treatment
Cool.
in real practice, even though this study is pretty small.
Love
Okay,
it.
so let's talk about placental insufficiency. This is something that would come up usually later on in the pregnancy, or your OB will tell you that you are at risk because you're older, or you have twins, or something like that. And in the case of twins, this can be true. Now imagine your body's trying to make two babies, okay?
Hmm.
Usually the placenta is a lot larger, and depending on, are they di, momo, twins, like, whatever.
Yeah,
We're not going to talk.
when you have twins, do they have one shared placenta or are there two placentas, one for each baby?
It depends on the type of twins.
Wow.
Identical versus fraternal, and then there's within that, within fraternal, there is like there's different ways that they can be.
Wow.
And there's some that are more risky than others,
Hmm.
like the risk of twin to twin transfusion syndrome, where one baby gets more nutrients than the other,
Hmm.
or, there's a lot of different ways that the risks can go. They
Hmm.
just require a lot more monitoring. Sometimes surgery, prenatal surgery for twin to twin, which is like an amazing. I watched a documentary about this one time. The guy who figured out the surgery, and it has saved so many babies. I mean, surgery on babies in the womb, and it just has to do with like clipping a little bit of like some
Wow.
vasculature
Is this
to
what
make it
happens sometimes when people start with twins, but then one baby sort of like dies or doesn't make
vanishes.
it?
That is like when it's really early on, and it's like vanishing
Hmm.
twin syndrome, and
Hmm.
that's usually from the integrity of like that embryo growing was just not
Got
going to
it.
make it. Twin to twin is like you're in your second trimester or your third trimester,
Mm.
and one baby is really not growing well as the other, and it's very clear. And then they do like Doppler studies; they can see the blood flow is shunting towards one, so they have to correct
Mm.
that. And they
Wow.
basically go in and they do this little vascular surgery, and it works like amazingly.
Oh my gosh, that's crazy.
Yeah, super amazing. Okay, so placental insufficiency, though, is like it's an inferred diagnosis based on things like the baby's growth, or sometimes if it's very obvious and severe, yeah, on a Doppler test. A Doppler is like where we can see when it has color, we can see blood flow, venous and arterial blood flow. And if it's like really insufficient, then we're like, okay, the baby's literally not getting very much blood from you. All the nutrients and calories and da 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 are in that blood, going, into their umbilical cord. Then there's some reason for that. Also, you can have low amniotic fluid, fetal growth restriction, things like that. So
Hmm.
there is a little bit higher risk the older you get from something like this happening.
Hmm.
Um, Again, though, this leads me back to sperm health.
Hmm.
This would be a sperm issue
Yeah.
primarily.
And probably a
Also,
cause of
maternal.
miscarriage too. Insufficient
Yeah,
placenta can lead to early losses as well.
right, right.
So,
Okay, so let's first do preeclampsia, then I'll do the other two. Okay, so
okay.
preeclampsia is again, I know I kind of like broken record here, but let me just say it in the context of preeclampsia specifically. Because of the way that the cells initially dig into the side of the wall of the uterus, they need to make really good vascular connections. And there's these like things called spiral arteries that are in that space. And if they go shallow or too narrow, they're not wide enough to have good flow. Like imagine pipe size.
Hmm.
You don't want skinny, tiny little pipes to flow your water. You want like nice, big, open pipes so we can have good water flow. We want good blood flow, okay? If for some reason there was a situation where we didn't get enough good, it's like, okay, imagine the roots of a plant that are growing.
Yes.
Like if a little sapling is growing and it doesn't have good deep roots or like a wide enough splay of them, or they're too thin, they're not going to be able to get enough nutrients. So
Mm-hmm.
what this does is it causes a whole stress on the perfusion system, perfusion of blood system between the mom and the baby.
Mm.
And it sets off this trigger of inflammatory mediators and oxidative stressors, and it causes a whole body, so systemic means whole body, systemic endothelial injury to mom. It does not affect
Mm.
baby as much. It's more about mom. And so in time, it can actually over time though affect baby, but it's usually the symptoms are seen in mom, and that's when we are like, okay, we need to induce, we need to get this baby out, because that's when we start to see effects on the kidneys and
Mm.
like swelling from endothelial. So endothelial meaning like a blood lining, blood vessel lining. Uh,
Mm-hmm.
the fluid is literally like leaking out of your vasculature and it's going into your interstitial space, and now all of a sudden you're very swollen, things like that. So
Mm. Wow.
this is like one of the main way that we think about with preeclampsia, and
Mm-hmm.
this is where aspirin works really well as an early treatment if we are worried about somebody, maybe they have a history of preeclampsia, or they are just at higher risk, like potentially they have twins or whatever. I'm not like every single person who is worried about this needs to take aspirin, but I totally think it's a reasonable treatment for if we think this is happening. The problem with aspirin treatment for preeclampsia is that you have to start it at like 14 or 17 weeks. It's you have to start it early.
And so how
Like
would
I'm for
someone know if they have preeclampsia? Is it early on in the pregnancy that they would know?
no,
Is it like
no.
so you just don't
So you would
know?
have to start this treatment and not even know if you're ever going to get it.
Mm. And so when are
And
the signs for preeclampsia usually showing up?
like late second trimester, and but mostly in the third.
And this is when there's like headaches,
High blood pressure,
hypertension,
headaches, yes,
or high blood
protein in the
pressure.
urine, and there's like a set of um gosh, I had a client. There's a set of diagnostic criteria that needs to be met. But so if you have just like one off blood pressure, that does not give you a preeclampsia diagnosis.
Right.
This happened to one of my clients before. It was like, what in the world? Like, no, it needs to be two, and they need to be separated by 4 hours, and there's all this other stuff that has to go by. You may have just high blood pressure in pregnancy, but it's not preeclampsia. Preeclampsia
Mm-hmm.
has also multi-organ system failure or like
Mm-hmm.
issue. Um, and okay, yeah. So I mean, I could talk about that for a lot longer, but we have too much to talk about still. So then now the other two issues are an abruption. So placental abruption is where there is a like premature separation of the placenta, like the whole part, like a huge part, or the entire placenta, um, before the baby is born. And
Mm-hmm.
obviously, this would have devastating effects.
Right.
It can be partial, and if it's partial, sometimes we can like catch it and immediately birth the baby. If it's too early, the baby's too premature, that doesn't happen as often, but it can. Like a a second trimester full placental abruption. This would be like on a sliding scale spectrum. It's like, okay, subchorionic hemorrhage is over here. Placental abruption is like full on. You know,
Mm-hmm.
it's away from the uterine lining. Baby is not getting blood anymore. There's no way for them to get oxygen. Um, it can't. The main thing is like pain. There's
Mm.
sometimes is bleeding too. You would make sense that you would see some bleeding, but sometimes people don't. They have internal bleeding, but they're not having vaginal bleeding, and so then they don't know that it's happening
Wow.
until it's sometimes way too late. And that
Right.
can be absolutely horrific.
Right.
Okay, and then the last thing is a retained placenta, which I had mentioned earlier, and that's basically like your baby is born, your placenta comes out, and a good practitioner, all practitioners should look really carefully at the placenta and make sure, is it whole? Is
Mm.
it a whole placenta where there's not like a chunk of it missing?
Mm-hmm.
And if we know that we had had a lobed one because we got an anatomy scan, then we could be, extra diligent about that. Lobed placentas are not that common though. So I don't
Yeah.
want anybody to think that that's like something you need to be definitely looking for. It's not that common, but there can be instances where there's a chunk of the placenta that is retained, like it kind of broke off in a way, which
Mm-hmm.
is sort of hard to think about because it's to me, placentas are so contained. Like it's such a
Mm-hmm.
clear contained organ, but I don't know, it break down, like it can kind of just so, but what can happen is inside the uterus, then after the baby and the placenta come out, your body is trying to like cramp back down. You're still having contractions. And in an effort of that, all the layers of tissue are coming back together and they're blocking off those spiral arteries. This is like cramps when we have our period,
Yep.
is we are cramping to get this blood out and to like shear it off the lining of the wall, and then to like not have hemorrhage, we only want to bleed a certain amount. And if there's a big chunk of placenta still on the wall that has not come out yet, we can't have proper cramping down of the uterus, and then blood flow stop. So what happens is women will have a postpartum hemorrhage.
Yeah.
It's not always the cause of postpartum hemorrhage. There's other reasons why it can happen. But it's one thing that if a woman is continually bleeding, they must assess and rule out, or a clot. Maybe the placenta came out completely. The whole placenta is beautiful, one intact organ, but she's bleeding. We cannot figure it out. It's like, okay, there could be a clot that formed where it's still impeding. It's still having the same effect. It's not allowing the tissue to clamp down properly. Because it's like this glob. It's like this putty glob on the inside of the wall that, okay.
Bleeding.
So to treat this, there's a couple options. You can do a manual extraction, which is where the practitioner is going to insert their entire hand and arm inside of you and scrape the inside of the uterus with their hand to feel and grab onto any clots or placental pieces that are still there. And thank God this has never happened to me. Oh my God, I didn't even think about the fact that this could still happen to me because I have another baby to
Oh my God, I feel like, I mean, what my midwife did to me was not that. Obviously, she didn't go up into my cervix, but what she did to me was so painful. I can't imagine having them go all the way up there. Oh.
All the way through the cervix into your uterus, scraping the inside of the balloon out.
Yeah.
From the women who've had a retained placental manual extraction, they say it is like blinding pain. You cannot even possibly compare it to anything else. Like birth is a piece of cake, So those women walk on water to me. I cannot imagine. But it's like you have to do what you have to do. And this is one of the ways that like midwives would do things at home, because you can't go in for an emergency surgery like a DNC. Now, providers in the hospital will often also begin with manual extraction, because if we don't have to do a surgery, we're not going to do it, even if it's very painful for the woman. It's a brief pain, but it's important because we don't want her to bleed out,
Right.
Sometimes they can, depending on the rate of the bleeding, they can ultrasound real quick and they can see, hey, is this what's happening? So we're not doing this for naught. But if it's a really dire situation, there's no time. We're just trying to save her life,
Yep.
And then a DNC, which is a dilation and curettage, which is the same procedure that could be done for an elective abortion or a miscarriage. It's where they're basically going to go in and like scrape the inside of the uterus with tools. And so same effect would be met there. There is further risk with things like DNC. So, you'd have to be weighing those risks if you can. I mean, again, if it's dire, then it's dire. So, okay, those are kind of all of the placental issues. I feel like this is like so
Crash
downy.
course on placenta.
Yeah, I know, guys. Hopefully this isn't so boring. Okay, so let's talk about the two different ways the placentas can come out, though. The birth of the placenta, often called the third stage of labor. So, first stage is all of the contractions. Second stage is the pushing. Third stage is the birth of the placenta. Well, second stage is like pushing and then getting the baby out. And then third stage is the birth of the placenta, because birth is not over until the placenta is out. And that would make a good t-shirt too.
I know. God, I have so many for you. I'm like, all the t-shirts I need to
Or a
make.
hat. How funny would it be?
Birth is not over until the placenta is out. Hashtag healthy as a mother.
What are you talking about? I have a confession to make that will probably knock the socks off of some of you crunchy moms. And please don't make fun of me for this, but listen, I don't make bone broth, okay? I don't. Sue me. I like to buy it instead. And maybe one day I'll get my act together, but for now I rely on brands like Fond to make real, actual bone broth from scratch, just the way that I would at home. Fond uses actual bones, not just rehydrated powders like a lot of brands. And their animals are verified regenerative, 100% grass-fed or pasture-raised, and the vegetables that they use are organic. And as you've heard us talk about in the past, there are certain foods, like bone broth, that have been used in pregnant and postpartum populations throughout human history, preferentially more so in those populations, due to their healing benefits on the body. So providing the connective tissue nutrition or optimal gut health and healing so that our bodies can make new life healthfully. Fond has several different flavors to choose from in beef and chicken broth, from unflavored to things like the classic garlic and lemon, to even a turmeric and black pepper with added health benefits. But then they also have foundational fats like tallow and lard as well. Make your family building season easy and choose Fond for your shelf-stable glass bottled bone broths that you can use in soups, with rice, or just for sipping like I do because they taste that good. Check the link in the show notes or go to fondregenerative.com and use code HEALTHYMOTHER for 10% off. and nourish yourself with fond. Let's talk about the physiological way that a placenta comes out, which would be, there's a term for it, of course. There's two terms. There's active management of the placenta, and there's expectant management of the placenta.
Mm.
Midwives will almost always, that's what they do. It's physiological, it's expectant management of the placenta, which means watching and waiting and knowing that the placenta is going to come out, 9 million times out of whatever.
Mm-hmm.
And it's not on a timeline, though, that sometimes practitioners in hospitals are comfortable with, but also that's because they don't see it. They don't see a placenta that comes out 30 minutes later, or sometimes an hour later or more. There's stories on the free birth side of things where people have their placentas in for like hours and hours and hours. Would I chill out with hours and hours and hours of placenta inside of me? Absolutely not.
Mm-hmm.
Because the risk is that the cervix is also starting to close pretty quickly.
Mm-hmm.
And if the cervix closes and you've got a placenta up there still, you got a big problem.
Yeah, that would be
You can't get it out. Okay, but also I hate giving birth to the placenta. I don't know why. There is something so terrible about it for me. It's like that feeling. It's such a deep, uncomfortable cramp. It's like a period cramp. Obviously, contractions are so much worse, but for some reason to me, I don't know. It's like you're lucid though. Like when your placenta's coming out,
Yeah.
you're like back in the room and your birth hormones are kind of gone and you have your baby and you like think it's all done and then it's not done and you're like, oh, I don't
Yeah.
want to do this.
Like very
But anyway,
jarring.
yeah. And it doesn't
I would
hurt,
imagine.
but it's hard. It's hard to push out a jellyfish when you've just birthed a rock. Okay.
Yeah.
Like you can't feel it. Like you can't feel that resistance and friction to push against. I don't know. It's very
Mm-hmm.
strange. I just don't like it. Anyway, so that's physiological birth. Active management of the placenta almost always includes Pitocin.
Mm-hmm.
And this is something that everybody who's giving birth in the hospital really needs to be aware of because they are giving people Pitocin in the hospital without any consent. They are
Mm.
just giving it either like an IM intramuscular injection, or if you already had an IV hooked up, they are injecting it into your IV without asking or saying anything to you. Now, in the case of a situation where there was an induction or an augmentation of your labor using Pitocin at any other point in the labor, then it is a good idea to have Pitocin for the birth of the placenta
Mm-hmm.
because Pitocin sits on the receptors, acts like oxytocin, but it's not. Your brain has not had the same oxytocin releases because of this reason. It's a feedback loop. And when artificial oxytocin comes in, the Pitocin, it kind of shuts off mom's brain's oxytocin in that sort of way. And so
Mm-hmm.
you would not have enough contractile strength of the uterus to get the placenta out safely. And the risk of postpartum hemorrhage is actually higher if we don't
Mm.
use Pitocin in the
Interesting.
birth of the placenta. But
Mm-hmm.
if you did not have Pitocin during your birth at all, then to me, this is crazy. Like, why are
Mm-hmm.
they not at least asking people? They'll just do it. And then people find out on their bill, their hospital bill, or they see it later or something. It's like, why? Just wait. And they're like, well, it reduces, postpartum hemorrhage. It's like, chill out. Like, there's no reason to think she's having a postpartum hemorrhage. Why don't you manage it when it happens? If it
Mm-hmm.
happens,
I
let's
know.
let her just have her placenta. And then if there's bleeding, we can do other things. Like, ah, it makes me
I
so mad.
know.
Okay.
I know.
So, but just
Preach,
know that.
girlfriend.
What'd you say?
Said preach.
I know. So it's like, okay, if you're birthing in the hospital, you need to have this as a conversation with the birth team, your doula, your partner, so that they can be watching you postpartum and ensuring this isn't happening if that's not what you want,
Mm-hmm.
or that at least that they're asking you and assessing the situation. Like, did we end up using Pitocin? We didn't plan to, but then we did. Oh, all right. Okay. Or, oh, shoot, actually, like, mom is exhausted. It was a 50-hour labor. Placenta's just not coming out. She needs some help. Okay. Or, whatever. Or
Mm-hmm.
the placenta's born physiologically, but then now there is hemorrhage, then Pitocin is an appropriate use. That is actually the purpose of Pitocin.
Yeah.
That is the purpose, is to manage postpartum hemorrhage, not for the induction of labor. Like,
Mm.
anyway, okay. Now let's talk about what to do with it afterwards.
Okay.
Okay, so first of all, you could just dispose of it.
Mm-hmm.
You could just throw it away. It's medical waste. And it'll go in like a medical, hazmat kind of, or whatever it is, hazardous material bin. Um, I'm not going to get into like our hospitals harboring placentas and selling them. Like,
Oh, I
I
was
don't
gonna
know.
say, like, isn't there like a whole movement with like skincare and stuff using?
Yeah, skincare,
Are there
stem cells.
stem cells in the placenta?
Yes, so many,
Oh,
so many,
interesting.
and in the cord.
Hmm.
Um, and yeah, I don't know what to think about. Do I think that it's happened in the past? For sure. Do I think it's like a huge underground operation happening all the time? No, but maybe I just haven't learned enough. I don't know. I'm just not interested in learning about that. Like, I don't know. I don't really care.
Yeah.
Maybe if I don't know. Even if I birth in the hospital, I'd still take my placenta with me.
Yeah.
So to me, I'm just like, that's some weird shit, and it's
Yeah.
probably happening, but I'm not looking into it.
Right.
Um, okay, then the most extreme thing that you can do is called a lotus birth. A lotus birth is where you birth the placenta and you keep the baby attached to the placenta through the umbilical cord until the spot at the baby's belly of the umbilical cord naturally sloughs off, which can take like 3 to 14 days.
Got it. So the
So,
placenta is out of your body. The baby is still attached to it, so you're carrying the placenta around like a bowl.
yes, you carry it in a little basket. The cord gets very firm and hard, just like
Hmm.
anybody who's had a baby before and they have that little cord stump and it turns into like a hard little mummified rock of of umbilical cord.
Yeah.
The entire length of the cord, which could be multiple feet, would be like that, kind of like this
Hmm.
hard piece of umbilical cord. Okay, and they put the placenta in a little basket with a bunch of herbs like rosemary and sage and thyme and different things that are very kind of like strong smelling and antimicrobial to preserve it so that it because it will start to break down and so that it doesn't smell. And one of the benefits is that it like kind of anchors mom and baby to the bed and to just being held only primarily usually by her.
Hmm.
But it's like if that's the whole goal of lotus birth, why don't we just have better boundaries?
Yeah. Right.
Like why don't we just say I'm not leaving this bed and no one's holding this freaking baby.
Yeah.
Like, get
Right.
over yourself. Sorry, I
Right.
just had a baby. Like, until I feel like I want to do it. But,
Hmm.
there's maybe other things, other spiritual things that I'm not aware of. But so that's called lotus birth if you've ever wondered about it. Then a very common one is people will encapsulate a placenta. So there are people called placenta encapsulators who've done a certified training that they know how to do it and handle things properly and, medically safe in their kitchen and stuff. So they'll take it home and sometimes they dehydrate it first or like boil it or whatever. And then they'll dehydrate it at some point and pulverize it into a powder and then put it into capsules, just like any other
Hmm.
supplement or pill. You cannot taste it. You cannot smell it. It's not like gross and weird in that kind of a way. Um, or sometimes people will eat a piece of the placenta raw, like right at birth in like a smoothie, or they'll just chew it, go straight to the mouth, chew it up. Badass. Okay, I did plan on doing that actually this time, or with Sunday's birth. And when push came to shove, my placenta looked super weird. The top of my placenta had all these clots on top of it,
Oh, weird.
like the maternal side, and it. I didn't in the moment because I asked my midwife about it later. I was like, "Why did my placenta look so weird?" She was like, "Oh, that was just the maternal side," because the sides that we see pictures of, like with the cord
Hmm.
sticking out of it, and the tree of life, and like all the beautiful vessels, that's the like baby side
Right.
of it. But the maternal side looks like mashed up brain. Like it's gross. Okay, it's not cute.
We're not feeling an appetite for mashed up
Yeah, it was
brain stew.
extremely unappetizing, but it was just flipped over in the bowl. So I was
Mhm.
looking at the maternal side and I couldn't figure it out. And I was too just like, whatever. I was so tired. So I was like, take it away. I don't want it.
And what are the benefits? What do people say are the benefits of eating the
Yeah.
placenta? Why would anyone do that?
Okay. Well, this is a really good question because I ate my first placenta
Hmm.
fully encapsulated. And then I had my second placenta encapsulated. And I took maybe 1 or 2 doses of it. And then I've had the strongest intuitive no about continuing. And I thought that was so strange. I'd paid like $250 for this service
Mm-hmm.
and I just like couldn't do it. And it's
Yeah.
not because when I did take it I felt weird. I have no idea. So it sat in my fridge until we moved to Idaho and then we just threw it in the trash. So I was just like
Mhm.
I can't. It like repulsed me. It was like no, just do not do that. I don't know why. I have no idea. But anyway, placentophagy is what it's called when people eat their placentas.
Mhm.
I used to want to think had a long historical basis, and that was kind of, and it was trendy. This is 2015. Okay, it was like everybody was doing this sometimes, and people do it a lot. And there's a lot of anecdotal stories of it helping people immensely.
Mm-hmm.
But the truth is, anthropologically, there is not a strong human history of humans eating placentas.
Hmm.
There is actually almost no that I'm aware of. And if this is something you're aware of, please send me the information. Instagram or my email, hello@milkmedicine.com would be great. But from the research that I've done, there is like zero context of humans eating placentas as part of like a birth ritual.
Hmm.
And that really would surprise me because the argument was, well, mammals eat their placentas. All
Right.
mammals except aquatic mammals and
Mm-hmm.
camelids, meaning camels and alpacas. All, and like, dolphins and whales, they don't eat their placentas, but all other mammals do. And it
Mm-hmm.
was like, okay, there must be something about this. Humans should too. It makes sense. So where I've come about this, and there is a couple of research studies that show the hormone levels in placentas, like very small research studies. I'm talking like there's 17 placentas in the study. And what it showed though is that there's a lot of different, there's estrogen, progesterone, and a lot of different metabolites. Those two are the main ones. And that there's a huge variance between placentas in their load. Some of them have absolutely active amounts that could cause physiological change in a body. Some of
Mm-hmm.
them don't.
Mm-hmm.
And the thought is that because birth is the biggest hormonal drop a woman will ever experience in her life, because the second that placenta comes out of you, you are cut off from this enormous amount of very high estrogen progesterone that you've been rocking the entire pregnancy. And in
Mm-hmm.
order to get into lactational physiology, we need those to drop, we need prolactin to rise, and
Mm-hmm.
immediately we're going into a different state. And I hate that transition. It hurts. It hurts me physiologically. Like day 3, 4, when milk is coming in, I am like a glass case of emotion. Like I can, and that's so common for people too, to
Yeah.
just like bawl your eyes out when your milk comes in. Probably not for you, huh?
No, I feel the minute the baby's out of my body, I'm like, oh my God, I have never felt better in my entire life. There's literally nothing better than how I feel right now. Yeah.
Oh my
Probably
gosh.
because I
Okay.
just feel so bad during the pregnancy, but I
Yeah.
also, I don't know.
Well,
I
and then
love
you like ride a
breastfeeding.
high of, you're having your baby and stuff.
I mean, I never get the
Um,
natural high of oxytocin because I've had to, have C-sections and things like that. But still, I just think that my body, I don't know, it likes being postpartum.
well, and you still do get oxytocin every time your baby's like skin to skin and breastfeeding and
Yeah,
stuff
that's
too.
true.
But okay, so the idea is that if we eat our placenta after birth, we are blunting that strong hormonal drop in edge,
Mm-hmm.
and it can feel better for the woman. And I do understand that. That physiologically does make sense to me.
Mm-hmm.
The problem is that some lactation consultants have noticed in women who have maybe a delay with their milk coming in or a low milk supply, and we cannot figure out why. Some women are more sensitive to those exogenous hormones. Exogenous meaning like you're taking additional hormone from some other source. Even if it's from you, it's still
Mm-hmm.
not the hormones that your body's making in that moment.
Right.
And that it can cause a low supply or contribute to not being able to make enough milk because you're kind of keeping it in a pregnancy state, or
Mm.
you're sort of giving it these little like hits of hormones that should be remaining low.
Mm-hmm.
Physiologically, purposefully should be staying low.
Mm-hmm.
So, where I've come at eating placentas is it does make sense to me. Okay, first of all, mammals eat their placentas because of the protection, because it's very smelly and they don't want to leave behind afterbirth um, for predators, is
Mm.
like the main thought. Secondarily, yes, it's like eating a humongous piece of liver or something. It
Mm-hmm.
is a lot of nutrients, and they've just
Mm-hmm.
expelled a lot of energy and nutrients, and it's like, cool, great. Like, there's a lot of benefit in that way. And to me, if we're going to eat placenta, then we do it at the time of birth like mammals do.
Yeah.
Because mammals do not dry and pulverize and encapsulate their placentas and eat it for weeks later. That
Right.
has never been done ever throughout human history except now. Okay, and
Mm-hmm.
it doesn't happen in the natural world either. So if we're looking to the natural world to educate us on how we should live now, what we would do is eat some or all, which that would be a lot to eat all of it, but eat it, a little bit of it if you really want to eat it at birth and then not again.
Yeah. That makes
Okay.
sense.
The things that we do see historically done though are burials.
Mm.
So placental burial is seen in lots of different cultures, and or like different ways to honor the placenta. Sometimes, so this is more modern, but you can do like a placental print, like with paint, and then they kind of like make a stamp of the shape of your placenta and with your cord and stuff. Sometimes you can like keep your cord and they'll shape it into the shape of a heart. There's other things that can be done if you want to, burying it under a tree or at the place of birth or in the country of birth or, something like that has another significant meaning that doesn't include ingestion if you don't want to.
Mm-hmm.
So, yeah, but then there are so many people that have had really good experiences taking their placenta, and they're like, I think that it prevented me from going into postpartum depression. And it's interesting because the postpartum depression medication that came out, the pharmaceutical, is just like a progesterone, basically. It's like,
Yeah.
okay, well, yeah, that would make sense. I mean, lack of progesterone hurts. It doesn't feel good.
Right.
And so for that reason, cool. But in women who maybe have a sensitive milk supply or sensitive to hormones, there can be this negative. So we never really know who are those people that are going to be that.
Mm-hmm.
And so it's just something to think about and consider.
So maybe taking it before your milk comes in and then being done, like if you're going to do it.
Yeah, but I
the
think that it
issue
could impede.
is it takes so long to get it back. Like if you encapsulate it, it can take a while.
Yeah, it takes
Right?
usually 72 hours, I would say, is pretty common. But also, we don't, I think, even if you did have it immediately, we need there to be this very dramatic drop and then in those two hormones and rise in prolactin in order to pull the milk supply in and then in order to pull it in robustly. So I feel like almost it would make most sense to take it at like 6 weeks after we've got a really good milk supply. But then now we can still definitely be dipping into a situation where we damage milk supply. So it's like,
Yeah.
I don't know. I know there's a lot of people that feel very, very, very strongly. They're like, I will always encapsulate my placenta. And I'm like, that's great. And you're probably not the type of person that had any issues with
Milk supply.
the way that your milk was. Yeah.
Yeah, I mean, I encapsulated my first placenta. I was totally fine with milk. And then I just didn't for my second. Intuitively, again, I just didn't feel like I needed to or wanted to. But one thing to note, if you want to do anything with any of the placentas, if you do have a hospital birth, you have to remove the placenta from the hospital the day of your birth. They will not
sometimes within like 2 hours.
Yeah, they will not let you just keep it there in a cooler. So
Yes.
just so you know that if that's important to you, you literally have to arrange for someone to come get it.
So they have to come and get it.
Often think about, but
yes, no, I'm glad you said it. So this will be the last thing I say is that if you're planning on going to a birth center or anywhere outside of your house, a birth center or a hospital, you must bring a cooler and 2 plastic gallon bags. That is going to be like the house of the placenta after it's born. And certain hospitals are really sticklers about this, where they are like super annoyed if it has to be gone within 2 hours, or we're disposing it, we're taking it from you. Strange, but yeah. So then you have that cooler as like, oh, these are snacks for dad, or like the birth team, because sometimes people are like, you can't eat during labor, depending on your hospital situation, So it's like snacks for dad, but it's really snacks for you. And then it'll be the place for the placenta later on. And then, someone has to come and pick it up.
Yeah. And then we won't get into this. Maybe we'll interview someone on this, but you can do, cord banking and stem cell banking with it. But that's like a whole conversation for another day.
Well, yeah. And that would have to be done. You have to choose delayed cord clamping or cord blood banking.
Right.
And yeah. Anyway, okay. Well, I hope you enjoyed and it wasn't too boring. And now you know every single thing there is to know about placentas.
Oh my God, I learned so much. I don't know about everybody else. Maybe you all knew all of that. This was just like a totally basic conversation. No, I think that was med school level. Like beyond med school level is great.
Yeah.
I love it.
I was watching some YouTube videos because the understanding of the chorion and amnion is tricky. It's like,
no, I think it's super helpful because I think when women are told these things or they have a friend who's like, oh yeah, I had placenta previa or whatever, and you're just like, like it's so hard to understand what you're actually talking about. For me, I love understanding root cause and what's really going on. And so it all makes sense. And I think we're all about empowering women with education and knowledge so they can make better decisions and choices. And sometimes you have to understand the background and the physiology of it. So I think it was great. Good job.
Thanks. Okay. Bye guys.
In order for others to hear this information, please leave a review with Apple Podcasts, subscribe, and share with a friend who would benefit from this content. Please remember that the views and ideas from this podcast are for informational purposes only and are not intended to be a substitute for medical care of any kind, including the diagnosis and treatment of any disease. Consult with your provider before integrating any of this information into your own healthcare plan. A healthier future starts now, and it starts with you.